Good evening, everyone, and thank you so much for joining our Woo You event tonight titled Contact Lens Indications in the Management of Computer Vision Syndrome and Digital Eye Strain with Dr. Giancarlo Montani. I'm your host tonight, Dr. Ariel Sorenzi. So I'd like to introduce our speaker tonight. He is all the way on the other side of the world in Italy. He is a professor of clinical contact lens application at the University of Salento, Italy. He has been involved in optometry education since 1988. And he has a private practice in Italy where does primary care and specializes in contact lenses as well, and has published numerous articles in optometric journals and has been invited as lecturer to several national and international optometry congresses. Here are his financial disclosures, all of which have been mitigated. And I'm going to go ahead and have Dr. Montani take it from here.
So thank you for this introduction, and thank you for this opportunity to share with you some information about the possibility to manage the digital eye strain with contact lenses, in particular way this evening in soft contact lenses. This is my disclosures, and this is my email if you want to ask me something or if you want to send me some questions. So digital screen is everywhere at home, and now you are follow me using a digital device, and for job, for other, everything is done with the digital screen in these times, and in these statistical results, we can consider then more than 13 hours by day are spent in front of some devices. And which kind of devices? So the computer is the most famous, but we have also the smartphone, the e-reader, the television, or the video games. All these devices can have some effect on visual system. And these effects are related to symptoms, because many individuals now experience eye discomfort and vision problem when viewing digital screen for extended period. The level of discomfort is related to the time used in front to the devices. And we have also a definition from the American Optometric Association, and they defined the digital eye strain as a group of eye and vision related problems that result from prolonged computer, tablet, e-readers, and mobile phone use. And these are the most important symptoms: tired eyes, dry eyes, eye strain and eye discomfort, irritated or burning eyes, light sensitivity, and blurred vision at distance and near. This is a very recent article published on this topic too, and we can find all the same symptoms. In these cases, we have more symptoms, but the most important as the same, because asthenopic symptoms and dry eye are the most important problems during digital eye system, during digital systems. But another important consideration to do is related to the age of patients, because normally we can consider that using digital devices, we use the near vision, and probably the presbyopic patients are more involved. But considering the results obtained by the Vision Council, we can tell that the age range more involved by the digital eye strain is related to the younger person. So person with accommodative amplitude more than enough to do or to perform near task without problem. And the percentage is very high, because the 73% of subjects present symptoms at an age below than 30. But we have also problem with children, because it was published recently that children attended classes as part of a remote learning strategy had more rapid myopia progression. There are several papers published now that found the effect of the lockdown on myopia progression. And this is a very important topic for us. But this child has also an increased frequency of dry eye and visual fatigue symptoms, and as they have also problems at the binocular vision. And it was found that children using the digital devices for more than 4 hours present abnormal vergence and accommodation response, and in particular way, convergence insufficiency. We have also to understand more about the interaction of digital system use with contact lens wearer. Contact lens wearer are very interested because they have also the relationship with the contact lens with the anterior segment, and this could increase the symptom perceived, as presented in this article, because contact lens wearer have a 65% of prevalence of symptoms compared with the 50% of no contact lens wearer. And the symptoms, again, are more important in contact lens wearer. And in this case, the most important symptoms is related to the dryness, followed by the burning and the other problem related to contact lens discomfort, as feeling of foreign body or excessive blinking. It was also found that the use of contact lenses compared with no contact lens wearer induce a more red eye, and very important for us, these symptoms appearance at the end of the day. And in another study, it was found that the time needed to have more symptoms is 4 hours. So if you contact lens user of digital devices has do this for a period of time below 4 hours, the symptoms are not so important. After 4 hours, we have a lower tear meniscus, and in this case is the quantity of tear film not sufficient, and for sure this introduce significant dry eye symptoms and a problem for wearers. It's also important to evaluate the bulbar redness, because it was found that VDT user present an increase of bulbar, limbar, and lid redness. It's also important for us to evaluate also in non-contact lens wearer and in contact lens wearer the possibility to have corneal staining, because this is also a sign of the possible effect of digital screen use and on the anterior surface. We have also in literature different interesting review. Well, I put in this slide just the most important, and we have to see together with which are the most important causes of the digital eye strain, because the first thing to understand is where we have to work and where we have to put a solution. As we can see, and this is another interesting article available on contact lens spectrum, the causes of digital eye strain can be divided in two different areas. One part is related to the screen. As you can see, the handheld as a smartphone induces some problem not related to the personal computer, because the distances of use is very important in smartphone user and not for the personal computers user. We have also to understand more about the environment. So the lighting or the position of windows can be other causes of digital eye strain. But we have no time to enter in depth in every causes. We concentrate our attention just in the problem related to the refractive and the oculomotor condition, and on the ocular surface condition, because these are more related to the contact lens wear. So it was found that the quality of the screen are very important to obtain a better accommodative response. So we know that the demand, the accommodative demand, is not the accommodative response. We can have differences. And when the accommodative demand is higher than the accommodative response, the difference between them is called lag of accommodation. If the response is higher than the accommodative demand, we have the lead of accommodation. In this case, we can tell that using an higher quality screen reduce the lag of accommodation. And in some cases, this is completely eliminated. And in case of myop, we can have subject with a lead of accommodation. So with an increased accommodation compared with the demand. We have also to consider which is the effect of smartphone on the working distance or the distance used. As we can see, the distance used for the smartphone is a very close distance compared with normal reading. We have distances, an average distance, distances between 32 and 36 is a little bit closer than the normal near working distance. But it's important also to consider the range, because some patient examined in this study put their smartphone at 19 centimeter or at 17 centimeter. It's not very difficult to see a child or young person using the smartphone very close to their face. But we have also to understand that reducing the distances, we have an increase of accommodative demand and an increase of convergence demand, increasing the risk to have symptoms during smartphone use. It was also evaluated what's happened when the patients use for more minutes the smartphones. And from the results of this article published on clinical and experimental optometry, we can see as the distance used during the smartphone read something, or during the smartphone evaluation of web pages or the other social media, the distance is reduced. After 60 minutes, we have a reduction of distance. So the patient or the subject using the smartphone, more time in front of the smartphone, closer is the distance of use. And it was also found in this article that reducing the distance increase the symptoms. So this is an important thing for us also during the measurement, because we have also to understand the real world of patients. And so if I have to evaluate the refractive condition, or if I want to evaluate the binocular vision condition of my patients, I need to ask him to use a smartphone, for example, to understand at which distance he or her can use it normally. About the refractive error, we have also to do another consideration, because as we have told about the quality of screen, the quality of screen need also the quality of the retinal image. And for this, low value of uncorrected hyperopia, astigmatism, or differences between eyes are very related to the digital eye strain. So what we normally can prescribe as low value of hyperopia in a young person, maybe in this case, or for some symptomatic subject, is the starting point for the management. We have also to understand more about the accommodative, because using the digital devices at near distances, the more important function, the most important function involved in this process is the accommodation. And for this, sometimes patients tell us to see near blur at near distance, but maybe is normal in a presbyopic patient, but not in a no presbyopic patient. They can refer us also about a post-work distant blur, and maybe this is another information for us, always related to the accommodative function. They can tell us also about the problem to change the focus from near to distance or from distance to near. And for sure, they can tell us about the problem, the eye strain at the end of near task, or general ocular discomfort. The most important part we have to consider, because we have literature on this about the relationship between eye strain and accommodative function, is the accommodative accuracy. The accommodative accuracy is the difference between the demand and the response. In this case, if we consider the demand is the ratio between 1 and the distance in meter to obtain the value in diopter. But this is not real, because normally accommodation has this kind of behavior, is a behavior that induce a reduced response compared with the demand. And this is normal in patients. Is abnormal when the LIG value is increased, as in this case. The gray curve, in this case, is the result of eye strain. And for us, it's important to measure this function maybe at the end of the near work, because this could be one of the conditions where the more related with the symptoms. Another function is the accommodative facility. The accommodative facility is we can call this function as the lubrication of accommodation. So the accommodation change focus in a very fast way, and this is normal. When we have a latency between the change of sight direction from near to distance or from distance to near, and the accommodation need the time to do this function, we have to evaluate where we can find the problem. The problem was again related to the accommodative fatigue, or maybe also related to the binocular vision. Sheedy, in an article published a couple of years ago, found that the symptomatic patients has a dysfunction not normal. This function can be measured in different way, and we will take this information in the further slides. Recently, the binocular accommodative facility was also measured, and after 60 minutes of reading on a smartphone, the value was reduced. So, in which way we can measure the accommodative facility? Inducing the subject to change the focus. The change of focus can be done simply in a simple way, reading something and to see something far, or maybe using lenses with negative or positive value to simulate the accommodation, the positive accommodation or the negative accommodation. We have also another function, very interesting and very well correlated with the eye strain. And this function is the accommodative microfluctuation. The accommodative microfluctuation are small dioptric changes during accommodation and can be measured with special autorefractor. And this is, as we can see here, this is the results obtained with a special autorefractor able to measure this fluctuation. And in these results, we can see with an higher value of frequency accommodative microfluctuation. And these values are related, again, with eye strain. Higher is the value, as in this case, higher is the eye strain. In a simple way, as we can check corneal topography, more red is present and more abnormal is the situation. It was evaluated also the associated phoria, but in this case, not every article published obtained the same results. So I think, again, for our aim, is better to consider which the scientific evidence have found the same results. So article where we have different or controversial results are not very useful for us, because we have also to understand which are the most important functions involved in the symptoms presented by our subject. The other part, and so we move to the other part of the problem. We consider now just the information related to the refractive, the accommodative, or the binocular vision system. But we have also to understand more about the effect of digital devices use on anterior segment, and in particular way on tear film. During digital device use, we have a reduction of blink rate, an increase of incomplete blinks, a reduction of lipid layer, and this is the consequence, an increase of tear evaporation, a tear instability, and an increase of meibomian gland dysfunction. As we can see here, this is a very interesting article, a review article published on Acta Ophthalmologica, and we can see how many studies published on peer-reviewed literature highlight the interaction and the increase of symptoms in digital device user compared with no digital device user. And also it's important to understand what's happened. In this case, in this graph, very, very nice, using computer, we have a decrease of frequency, blink frequency, an increase in complete blinks. I told this before, but this increase the dry eye circle. And we know this is the first step is the excessive evaporation. But after this, we have hyperosmolarity, inflammation, damage on the surface, and problem, and not problem with the distribution of tear film. And so it's not just the starting point, but the consequence over time of this alterated environment for the eye. We have also to understand how important is the number of blink reduction. And it has been shown that VDT use may reduce the spontaneous eye blink rate approximately by the 60%. So we have subjects using computer or VDT remain with the eye open for a very long time. And we know the blink is very important because these reproduce and these spread again a new tear film on the ocular surface. Remaining the eye open for a longer time, our patients are more exposed with the problem, with the evaporative problem and the problem on the ocular surface. It was also evaluated the importance of the incomplete blinks, because reduce the number is a problem. But incomplete blinks are considered a greater contributor factor to tear instability. And this is also important for us, because with the blink, with the complete blink, the tear film is well spread on the ocular surface, and the meibomian glands are squeezed to produce the lipid layer necessary to protect from the evaporation, from the tear film evaporation. We also we have also problem related to the evaporation to the desiccation of the corneal lens if we talk about a contact lens wearer, but we can have desiccation in no contact lens wearer too. But in contact lens wear, the desiccation of the lens induce a loss of water, considering soft contact lenses fitted, and this reduce or modify the shape of the lens. The lens are more steep, and with the loss of water by the polymer, the osmolarity of the lens can increase. And again, this increase of osmolarity can have effect on the ocular surface too. Another important part is related to the optical effect of the tear film. We have many articles published in literature where the tear film instability was associated to the visual acuity or the functional visual acuity. So the change of visual acuity induced by the instability of tear film. And this kind of instability, again, is correlated to the microfluctuation of accommodation. And we see before that microfluctuation of accommodation are also related to to eye strain symptoms. So, as we can see in this video, if the tear film is not stable on the anterior, on the cornea or on the anterior surface, we have problem. So we can have a problem in the periphery related to the desiccation. But if the instability is inside the pupillary area, we have also an increase of eye-order aberrations. And as we can see in this graph, the increase of eye-order aberration is again related to the eye fatigue. So it's important for us to maintain very stable between blinks the tear film. And we spoke about a problem related to the smartphone, because I told that using the smartphone we can patient normally reduce the distance, but using the smartphone we haven't a problem related to the computer use, because normally using the smartphone we do this one. So we have the line of sight lower, not in primary gaze direction, and my anterior segment is as a lower exposure correlated to the normal lid aperture using a computer. So you can see this because now I see my screen and now I see my smartphone. As you can see, my lid aperture is different. And in this case, using the computer, the area exposed is higher. And again, the tear film instability in this case is more, or the dry eye symptoms are more evident. Using the smartphone, this seems not the most important problem. We have to find the problem in smartphone user in the refractive or accommodative, and not in the dry eye, in the tear film instability. And this was supported also by the results obtained in this article published on ophthalmic and physiological optics. The authors focused their attention on two different points. And the first one is that contact lens wear has no addictive effect on signs and symptoms of dry eye when using digital devices for a short period. And the screen position may be explicitly relevant in contact lens wearer because handheld devices being held closer and in a lower gaze, but computer is in another position. So again, this support was found in the previous article published on optometry and visual science. So after this review of the most important causes of digital eye strain symptoms, we have to move to the part of measurement. We have no time to enter in depth in every kind of test to do. We have just to understand more about the specific procedures useful to understand more about the digital eye strain and to understand which could be the most important cause. To start, I suggest to use the questionnaires. Normally, we are using questionnaires for dry eye, but we have also questionnaire for other evaluations. There are two different questionnaires for the evaluation of computer vision syndrome. Both questionnaires are validated, and so you can use what you prefer. Maybe if you want, you can send me an email and I can forward you both questionnaires. The first one is a questionnaire done by this Spanish group, and in this case, the different symptoms were evaluated considering the frequency and the intensity. At the end, the score, the results, can be evaluated and a final value can be calculated. This is very important for us because if we start management of digital eye strain, we have to understand if our procedure work in the right direction, reducing the symptoms. And it's also important to understand how much our treatment can reduce the problem presented by the patients. Another question, this is also from a Spanish group of researchers, and results of the validation was published on investigative ophthalmology and visual science. Again, is related to the frequency and is related also to special condition of the real world. This questionnaire was used in different clinical studies just to understand if the treatment worked well and in which way the treatment changed the quality of life of the patient. And again, in this case, we can't obtain a number at the end. So it's good to understand if we add something in a special area, but we have not the final number obtained with the previous questionnaire to understand if the whole symptoms are changing. About the measurement, I suggest to use in clinical practice, maybe you do this, the retinoscopy, the dynamic retinoscopy. In the dynamic retinoscopy for our aim are important to evaluate the accommodative response. We have two different ways to measure the LIG of accommodation, the MEM retinoscopy or the not retinoscopy. In literature, I found more positive feedback about the use of the not retinoscopy. As you can see here, we have patient. The patient fixes something in this. This is the target. So our patient reads something here, and the operator with the retinoscopy try to find the neutral point in retinoscopy. So in this case, we can consider and we can measure which is the LIG of accommodation, because we know this distance, we can measure this distance, and the difference between the value of these distances in diopter, so one on the distances in meter, give us the lag of accommodation. In this case, our operator measuring a LIG of accommodation because the neutral point is far from the point of fixation. If operator C at the distance of target perceive a movement on the same direction of the reflex and not against as in the case of lead of accommodation. We have also to use the flipper for the measurement of the accommodative facility. The accommodative facility is, we told this before, is the quality of the change of focus of accommodation. For evaluate the digital eye strain, we can suggest the use of 1.5 diopter flipper, so plus and minus 1.5, and to measure the number of cycles in 90 seconds, because it was found that the symptomatic subject has a reduced number of cycles in 90 seconds. One cycle is the use of negative and positive lens in front to the eyes. And so patient has to see something close, near, and we ask him, we ask to tell us when the target is clear with the negative and with the positive lens. The time or the number of complete cycle is useful for us to understand more about the symptomatic subject. We have also some autorefractor. There are different instruments, not many instruments, because one is the Speedy K2, another one is the N-Vision from Grand Seiko, because both autorefractor can measure in a range of time the changes of accommodation. But the Speedy has the way to judge at the end, which is the possibility to correlate the accommodative microfluctuations with the eye strain. With the N-Vision Grand Seiko open field autorefractor, we can obtain just the value, but we have not some relationship with the eye strain. Moving to the anterior surface, we have, again, no time to speak about every kind of measurement, but these are normally used in clinical practice. I focus the attention just in one ratio very useful for us. The OPI index is very useful because it's the ocular protective index. The ocular protective index is the ratio between the non-invasive breakup time and the interval between blinks. And the normal value must be higher than 1, because in this case, we are sure that the blink starts before the instability of tear film. But when we have, this is in normal subject or in dry eye patients, but not normally in VDT users. For this, you can do this, you can measure the OPI index in your clinical practice, but the blink interval is normal because it's not related to a special task for patients. And so we have also to recalculate the OPI index, considering the possible effect of the reduced number of blinks in a minute. In this case, you can use or you can multiply the IBI by 3.5 to consider the effect of blink reduction during VDT wear. So in this case, the non-invasive breakup time measured in your practice, the interblink interval measured in your practice, but these values can be increased by 3.5 times to consider the possible effect, the possible negative effect on tear stability or in OPI index when patients use the computer. And again, also in this case, the expected value must be more than 1. It's also important for us to record the bulbar redness and the cornea staining grading, because as I told before, bulbar redness increases. And if we want to manage the situation, we have also to understand if the treatment can reduce the bulbar redness or can reduce the cornea staining. We can use the grading scales. We have different grading scales, or maybe we can use some software available to quantify in a very accurate way the bulbar redness and the cornea staining, and it's possible also to compare the results over time. And we can move now to the prescriptive condition. These are just suggestions for refractive errors. As we see before, hyperopia, astigmatism, and anisometropia in symptomatic patient must be full corrected. We have to do some kind of consideration for myopic patient removing the spectacle during near task, because in this case, maybe the relationship between the reduced accommodation and the convergence obtain a better balance. I can, in this case, maybe the condition obtain a good balance using some positive. And probably this is the case of anisophoric patients. And reducing or removing the spectacle lost the accommodative part, and on the same time lost the accommodative convergence, then increase the aesodeviation. We have also to understand more about the prescription of positive, so the addition. Normally, we think that the addition are just for the presbyopic patients, but sometimes the positive values can be useful also for younger person, because in presence of near esophoria, in presence of IACA, or when the LIG of accommodation is high, the use of a low positive addition can support patient in a particular way if is a symptomatic patient. And now we can move, and we arrive on the final part of this webinar. We have to start speaking about the management of digital eye strain with soft contact lenses. The first things to tell is, okay, so if we need a positive addition, we can use in young person the common multifocal lenses in a off-label way. This is true in part because we have to remember that the multifocal lenses are designed to manage special optics and a special condition. The presbyopic eye have an increased positive spherical aberration and present a reduction of pupillary diameter. And so the design to manage the presbyopia in these cases are not so perfect for eyes with lower spherical aberration and bigger pupillary diameter. Some evidence was found using the center distance multiconcentric bifocal, and in this case, the author found a better accommodative response, so a reduction of LIG of accommodation. And in some cases, the patient moved in the lead direction of accommodation. And so we can tell in this case that the addition introduced by the lens, the multifocal lens, can have some effect on the accommodative response too. We know multifocal lenses are now used for the myopia control, and this is the majority of articles published in literature are done in myopic subject, because the aim is to understand more about the possible effect of multifocal optics on accommodative function, with the aim to understand in a better way the possible role of these optics in myopia controls. In this direction was the results obtained with a center distance multifocal lens with an addition of 2.5 diopter. In this case, patient exhibited a reduced accommodative response, so a different result compared with the previous article. But the researchers found an increase of exophoria, and when the accommodative demand was higher, so reducing the distance, the exophoria increased with this kind of lenses. But we have also lenses dedicated. We have a design on the market. This is a monthly lens obtained with a multi-aspheric anterior surface. This is the behavior, the optical behavior of this lens. So it's a light positive power in the center of the lens. We have some evidences about the benefit to use this kind of design in during the smartphone use. Again, in this case, was measured the change of accommodative microfluctuation during smartphone use compared with the equivalent spherical design in this case, we have not evidence about the effect on symptoms because this was not evaluated. But we have the objective effect of the lens on the microfluctuation of accommodation. In our university, the University of Salento, we did also a study using the same device. In this case, we haven't used the smartphone use, but we use the computer. And we fitted these lenses in a range of subject with young subject, so subject with accommodative available, and with a not very high refractive condition. And the first evaluation we did was the measure of the visual acuity, because as as I told you before, if the quality of vision is not good, we have problem in the accommodative responses. So it's important that the quality of retinal image is higher than possible. In this case, as we can see here, using the best correction with spectacle, or the best correction with spherical design, and the best correction with the special design for digital eye strain management, we haven't found significant differences. It's a little bit low, but not statistically different. We haven't found also differences in the eye order aberration, measuring the condition before to fit the lens, with the lens on, spherical, with the spherical design, and with the design for the management of eye strain. We found differences in the spherical aberration, because in this case, the biofinity or the lens measured with the special design induced a shift of spherical aberration from positive to negative direction. We have found also an increase using the design for the digital eye strain management. We obtain an increased number of cycle per minute, and so a better accommodative facility. We measured also the accommodative microfluctuation, and also in this case, we obtain a lower value of high frequency of microfluctuation of accommodation that are related to the eye strain. We obtain also a value numerically lower than the baseline condition. And we consider also the differences in the answer obtained using the the questionnaire, the CVS 17. And for the majority of a question, as in this case, after some time working with your computer, you have to strain to see well, or other question, the design dedicated for the reduction of symptoms work well. But one question for me was a little bit strange, because if I consider this question, while I'm working, I have to close my eyes to relieve eye dryness, I'm supposed to obtain the same results, or not a significant difference, because the lenses are done with the same material. But reading this article is important. Don't forget that symptoms related to dry eye and binocular vision disorders overlap. And so subject with symptoms of discomfort while wearing soft contact lenses may be experiencing a concurrent or standalone binocular disorder. So in this case, we have not to forget to consider the symptoms as the result of effect of dry eye and, again, binocular vision discomfort. About the contact lens material, it's important to evaluate what's happened if the lens is not well wetted, as in this case. So if I start again, you can see here how few seconds need the lens to be dewetted, and how more time the lens B need to lost the wettability. We can see this also using the Placido disc of a common topographer, or we can see in a more sensitive way using the interferometer, as in this case. So in this case, the lens is a little bit contaminated, but the quality of the surface is better than in the lens A. So it's very important for us that the pre-lens, as for the tear film, the pre-lens tear film between blinks must be very stable, because if the surface lost the wettability, we have a chemical problem that increase the hydrophobicity, and this condition can't be eliminated just with a blink. We need eye drops to change again the matrix, the chemical matrix on the surface. For this, many lenses now have different procedure that improve the wettability to maintain more stable the pre-lens tear film. We have lenses with internal wetting agent. We have lenses with no surface treatment and special technology as the aquagen. Or we have also lenses releasing something. And we have also special lenses covered by water gradient surface, or lenses with external wetting agent, or lenses with surface treated by polyethylene glycol treatment. There is a treatment on lenses who improve the wettability and maintain more stable the pre-lens tear film on the surface. We have also evidence that eye drops are very useful, are normal, very useful, but eye drops are very effective in dry eye symptoms induced by DDT use. We have also evidence about the effect of the cleaning eye drops during the contact lens wear to improve the contact lens wettability and to improve the quality of vision of patients. It was found that the 70% of reusable contact lens wearer who experience dryness while use digital device use wetting drops, but it's important also to prescribe the right products useful to manage the situation. Maybe products with the possibility to reduce the evaporation. Maybe something with liposomal in the formulation, useful to maintain for more seconds stable the tear film. We have also to suggest a cleaning solution with wetting agent inside, because it was found that are very useful to reduce the symptoms of dryness. Or maybe we can move we can move on a daily disposable modality to have every day a new well-wetted lens. We have also evidence about the effect of omega-3 consumption to reduce the dryness symptoms. But we have not evidence today about the rule of 20-20-20. So it seems that 20 seconds to rest is not enough. Maybe we have to change this rule, increasing the second to rest, to see in another direction. But it's also important to explain in a very clear way that the break is done looking something at the far direction and not looking the smartphone, because in this case we have not positive effect. But again, this article published recently don't support this 20-20-20 rule to prevent the digital eye strain. In conclusion, digital eye strain is a very common problem in young adults. Its management with contact lenses start to compensate the refractive error and to obtain the best corrected visual acuity as possible to improve the quality of vision, because in this case, we can reduce the effect of possible microfluctuation of accommodation. with the consequence of symptoms. Not all multifocal lenses work well for this aim. We have also to evaluate the on-label products for the management of digital eye strain. It's also important the use of well-wetted material, and is also important to consider the use of eye drops, and to use the right frequency of substitution. So thank you very much for your time. Thank you very much for your attention. And I hope my suggestion can support you in your clinical practice. And I'm available to receive your questions or your suggestion to improve this webinar. Thank you very much.